So,
and which is not there. Small eyes normally don't tend to have lot many flat corneas. There's the smallness of the eye which actually does. So that's an issue that what you have rightly said is that, and that should be message, that we should not make the cornea steeper than 48, 49.
okay. So we move on to the next talk, and that is by Dr. Chitra Ramamurthy, and she'll be talking on enhancement approaches in regressions.
You can see my screen.
Yeah.
A very good evening to one and all of you, and hats off to Namrata and her team for running the whole show so meticulously and such a brief notice to everybody. I have a lot to learn from her. So my due is to talk on enhancement approaches for myopic regression. So when we talk of regression, we need to realize that it's multifactorial. It could be a high refractive error. It could be a thin residual stromal bed. It could be eyes where you have erroneously used a small optic zone, a high astigmatism, older age group. If these are associated with dry eye status, some of those eyes with progression of axial length and a myopic shift, and about the latent hyperopia unraveling, which has been discussed here. So then the responses are also multifactorial. Essentially, regression is all about epithelial hyperplasia and remodeling which occurs. And if there is more inflammation, there is an increased epithelial response, as it could happen in a dry eye status. Again, altered re-innervation patterns could trigger regression. Again, the steeper gradients which are created when you're doing high corrections, be it a myope or astigmatism or a hyperope, these again increase stromal remodeling and increase the epithelial response. And what has been seen is, especially in those thinner stromal beds, there's a forward protrusion of the posterior lamellae, and that could also cause a myopic shift, although temporarily you do try IOP lowering drugs. Again, because of the architecture of these flaps, the microferritum flaps, which were used more often earlier, against the femtoflap, it's seen that therein the regression is more. And surface ablations, regressions are again seen in higher corrections, which limits us in correcting in surface ablations, although there are some who still manage to do it with a higher dosage usage of mitomycin. And when we look at the percentage of enhancement, it clearly tells us that in Lasik, there is more significant chance of regression as against SMILE, which is less than 2. Now, we also need to investigate and plan the course of management. So a very essential step is to look at a slit lamp evaluation. Are you able to define the flap edge? Do you think there's more fibrosis along the flap edge? Is the flap centered? How is the hinge looking? Is it a little low hinge? Would you really consider doing anything on the cornea in these eyes? You need to do a careful look at the topography, look at the corneal thickness, see whether there's a pachymetry progression which should warn you that things may not be as rosy. Look at the surface regularity, whether it's an asymmetric bow tie or skewing or inferior steepening. Look at the Q value. Is the cornea already very hyperprolate or oblate when you would reconsider doing an enhancement? Again, look very carefully at the anterior and the posterior float. We need to rule out any suspicious elevation points. It also makes sense to do an abrometry. Look at the pupil size, the optic zone which has been used. Would you want to enlarge the optic zone when you're doing an enhancement, when the patient is quite disturbed by the primary vision? And these are all old cases, not now. I don't think we ever have an issue of because of the optimal laser delivery system. And of course, you need to look at whether there is a higher order aberration which is already caused and the point spread function is there. Would you go about regularizing the topography in these eyes along with treating for the regression? Epithelial maps give us a lot of information, and you can actually accurately plan what is the amount of epithelium which you're going to remove when you're doing these surface ablations. In fact, if the hyperplasia is more, it even makes sense that you do a PTK alone and look at whether how the residual refractive error is there. Would that itself suffice? It makes great sense to do a biometry in all these eyes with regression to rule out an axial length elongation or a progression of myopia. And ASOCT, besides giving us information on the epithelial thickness, it also will tell you about the flap thicknesses, whether it's an irregular flap, which you're probably going to lift, whether the flap is uniform, what is the status of the flap. And again, most importantly, we need to do a dry eye evaluation and very aggressively treat the dry eye status. And therein again, you would even defer a treatment if the dry eye status is bad. So then these are the different options which have already been discussed partly, like would you do a flap lift? Would you do a flap recut? I think we hardly ever do it now. Would you do a surface ablation as a very safe option? Would you combine it with cross-linking? Is there any sense on doing a mini flap over a flap if the flap was very thick? Would you, and as Ritika so beautifully discussed about the smile-related enhancements, would you convert the cap to a flap? Would you do a thin flap Lasik if the cap was thick? Would you do a smile over smile? Or would you rarely do a phakic IOL? So the determinant of each procedure, like when would you do a flap lift? It makes sense that we lift the flap only if the treatment is less than 3 years. It's very important to define the flap edge and ensure that you do a smooth lift of the flap without surrounding epithelial disruption, because you do not want to seed in any epithelial nests. And it's also important that it should be a centered ablation within safety parameters. We should be very conscious that we should not lift thin flaps, buttonhole or irregular flaps with low hinges. And if the flap lift is actually considered beyond 3 years, like a lot of epithelial hyperplasia is there and you feel no point going and doing a PRK again in these eyes, it makes sense to then debride that epithelium a little beyond the flap margin all around. So that itself would ensure that there is no epithelial ingrowth. Now, supposing the original flap is decentered at small, then you could take a deeper cut, a little larger diameter if the corneal thickness allows. You could do a mini flap over a Lasik flap if the Lasik flap was very thick, these are more theoretical discussions. But what we also need to remember that if the plane of cut differs, there could be fragmentation, irregular astigmatism, and it's actually not a preferred option. Now, this is just to show a little decentered flap wherein a deeper flap was created and the flap was lifted and treated. Surface ablation apparently looks as a very safe option in all situations. And you could actually take a call whether you're going to do a wavefront optimized treatment or if it's a irregular topography, whether you do a topo-guided approach. And that comes as a great solution in these difficult moments. And you could actually incorporate the epithelial thickness and customize your PRK treatment. Mitomycin is absolutely necessary to address his, even more so in an enhancement case. And it could also be combined with low fluence CXL, especially in borderline CCT and hyperopic ablations. We do realize that surface ablation options have really expanded because now you could do regression, enhance in post-smile, post-RK, complicated primary Lasik procedures, again, always combined with mitomycin. And I think we should remember that you could expect microstriae when you're ablating on a thin flap. And even the post-op regimen, if there is a delayed epithelial healing, you might have to leave the bandage contact lens for a longer time and use more lubrications. Smile, I feel it's a bit redundant to discuss after the way Ritika had spoke, but more for completion. We could look at enhancement, like whether depending on the flap thickness, cap thickness, the stromal bed thickness, and also keep in mind whether the patient desires to remain flapless. And if the patient desires to remain flapless, PRK makes sense. And because anyway, all that we are doing in regression is treating small residual errors. Of course, a thin flap Lasik, if your original cap has been thick, is possible. And of course, doing a primary smile anterior or posterior. And circle software makes true sense if you are wanting to treat regression beyond PRK and of course, phakic IOLs. Again, when it comes to PRK, you could do an wavefront optimized or a topo-guided augmented with mitomycin C, especially for decentered ablations. A topo-guided really works well, but it helps to take the ASOCT inputs. And again, unlike what Ritika said, I did go through a lot of studies. PRK and smile, I do not think that the inflammatory response is more, that the haze is more, but maybe she would have some sound articles. And thin flap Lasik, again, it has to be very, very sure that the cap is really thick because it could impinge on the original interface. You could actually create a vertical breakthrough because the flap is going to be very thin, and there could be bubbles which create punctures in the corneal stroma. Secondary smile, I have very limited experience. I do understand that Sri Ganesh has done anterior and posterior smile procedures, and it's not done too often. And circle software again has been very well shown. Like largely we would prefer to do a D cut, although as she had said that the A cut is going, not creating a lamellar ring and or going deeper or more superficial to the pocket. And in D cut, you go right in the same plane and create a lamellar ring, and then go ahead and do a junction cut and lift the flap. So I'm just showing how the flap gets lifted and how routine this procedure is. So essentially, when you're thinking of doing regression treatment post-smile, it really makes sense to do a PRK procedure, or if you want to do a circle software, a D approach would be most ideal. Phakic IOLs and regressions are essentially only if there's a large residual error, supposing there has been a progression of myopia. But otherwise, I really don't see whether a phakic IOL has a role to play, because most of the residual regressions enhancements are done for small amount of regressions, unless it was a surprise and a patient has come from elsewhere, which is always the cause, because we don't create such huge problems, do we? So I would like to conclude that we have to remember that all the complications in a primary LASIK procedure has to be kept in mind. So you need to anticipate epithelial ingrowth. You have to strategize your treatment protocols. You have to ensure that haze is countered most effectively. You have to be careful that you do not miss out an ectasia. DLK has to be anticipated. There could be a rare case of infections, and increased dry eye status has to be countered most effectively. But on hindsight, we can say that well-investigated regressions can definitely be well managed. Thank you.